Good afternoon, good morning, good evening, everyone. We can start. It's at the top of the hour. Welcome to this July's LabCoP extended session. And my name is Collins Otieno, and I'm excited to be your host. Today's session will focus on the WHO's Ntb strategy gaps and how we can fill them. The strategy requires universal drug susceptibility testing and treatment for all people with tuberculosis. But unfortunately, only a few of those with the drug resistance tuberculosis get treated. This is impacted by the lack of diagnostic tools or the presence of cumbersome and assays that require sophisticated laboratory infrastructure. So this webinar will focus on one of the tools that have been developed by the Cepheid called the Xpert MTB XDR Assay. And we are privileged to have two presenters from NHLS and also from the WITS Health Consortium. So the first presentation will look at the performance evaluation of the Xpert MTB XDR assay, and will be presented by Anura David, who is an R&D project manager at the National Priority Programs at NHLS and WITS Health Consortium. This will be followed by a second presentation that is looking at the field implementation of the Xpert MTB XDR laboratory perspective by Dr. Pedro da Silva, who is a pathologist and operations manager at the National Priority Programs at NHLS. Also to note that we have simultaneous French translation, so please log into the correct channel, and also ensure that for questions that you may have, post them in the chat box, and we'll address them at the end of the presentation. So over to you, Anura, for the first presentation.
Thank you, Colin. Sorry, I'm just pulling up my presentation. Okay, there we go. A very good day to everybody. I'm Anura David, and today I am going to be speaking to you on our study where we evaluated the performance of the Xpert MTB XDR assay, or XDR assay as I'm going to be referring to it. I have a few disclosures. Of all the individuals who were diagnosed with TB in 2019, approximately 500,000 of these developed RIF-resistant TB, of which 78% developed MDR TB. The rapid diagnosis and appropriate treatment of drug-resistant TB is therefore essential to prevent significant morbidity, mortality, and further transmission of TB disease. There are available second-line diagnostics available, such as the WHO recommended MTB-DR-SL assay, but this is a complex assay to perform and requires laboratory infrastructure. The Xpert MTB XDR assay is a lower complexity automated molecular assay for broader resistance detection, suitable for use at lower levels in the healthcare system. The XDR assay produces results within 90 minutes. It has the same easy-to-use process as the Xpert MTB RIF Ultra assay and is performed on the existing GeneXpert platform equipped with 10 color modules. The assay also has onboard internal controls which ensure that both the cartridge, the assay, as well as the instrument is performing optimally. In addition to MTB detection using the INHA promoter region, the assay is also able to detect resistance to INH, ethionamide, the fluoroquinolones, amikacin, kanamycin, and capreomycin. It is also important to note that an instrument with a 10-color module is also able to run any other Xpert test. In this multi-center clinical study to assess the performance of the XDR assay for INH and second-line resistance detection, the study was performed across 3 countries and 4 sites in India, Moldova, and South Africa. Also to note that the sites that were chosen are sites that have high drug-resistant TB rates. The primary objective of the study was to determine the diagnostic accuracy as well as the operational characteristics of the XDR assay. The secondary objectives was to assess additional performance characteristics, including direct performance versus performance on cultured isolates, performance between sites, by smear status, by gene target, and compared to the Bruker-Hain MTB-DR+ and MTB-DR SL line probe assays. In order to be enrolled on the study, participants had to be at least 18 years old, and they had to have symptoms suggesting pulmonary TB, for example, a persistent cough. In addition, they had to have at least one drug-resistant TB risk factor, such as having had a previous episode of TB or having been exposed to a community or family member that had been diagnosed with MDR TB. The participants also had to have an MTB positive and a valid RIF-resistant profile by either the Xpert MTB RIF G4 or MTB Xpert RIF Ultra assay. The participant also had to provide informed consent and be able to produce an adequate quantity, at least 3 moles of sputum. So patients presenting to healthcare facilities at each of the 4 sites for routine TB diagnosis were approached and invited to enroll in the study, provided that they met the inclusion criteria. Once the sputum was received at the testing laboratory, the sputum was homogenized using glass beads. A fluorescent smear was prepared. In addition, an XDR assay was performed using 700 microliters of the raw sputum, and the remainder of the sputum was subjected to a NaOH decontamination process. The pellet was then inoculated onto a midget and LJ culture. Once the midget or LJ culture flagged positive, the XDR assay was repeated. In addition, both line probe assays as well as phenotypic DSTs and sequencing was performed. In total, 710 participants were approached and enrolled at the 4 sites between July 2019 and March 2020. Of the 710 participants, 611 had an MTB positive midget and was included in the analysis. The reference standard was a combination of the phenotypic DST or sequencing results. Of the 611 participants, the median age was 37 years. 35% of the participants were female, 16% were HIV positive, 81% were RIF resistant, and 24% were smear negative. For performance of the assay, approximately 3% of samples tested on the XDR assay produced an MTB invalid result. For drug resistance determination, the invalid rates or the indeterminate rates varied from 0.3 to 3.5%. It's also interesting to note that the invalid rate was higher for smear negative samples as compared to smear positive samples, that's 6.2% compared to 0.2%. The XDR assay performance compared to the composite reference standard using both direct and culture isolate samples produced very similar results. For INH, fluoroquinolones, and kanamycin resistance determination, the assay had a sensitivity of greater than 86%, and the sensitivity was lowest for ethionamide resistance at 54%. A comparison of the performance of the line probe assays versus the XDR assay showed very similar performance between the two assays when compared to culture DST. When stratified by smear status, the XDR assay performed better on smear positive samples as compared to smear negative samples for all drugs except for INH, where the sensitivity was similar irrespective of smear status. So in conclusion, there was similar performance demonstrated using the XDR assay on direct sputum and midget. The assay had a sensitivity of greater than 90% for INH and fluoroquinolone resistance determination, and a specificity of greater than 98% for all drug targets. There was almost identical performance between the LPAs and the XDR assay. And the XDR assay also demonstrated better performance on smear positive specimens. Additional details for our study can be found on our manuscript that has been submitted to Lancet Infectious Diseases and is also currently available at MedRivs. And I would also like to acknowledge and thank all the individuals who helped make this study a success. Thank you so much.
Thanks, Anura. So we'll go ahead with the second presentation by Dr. Pedro. And please post any questions that you may have in the chat box.
Good afternoon, everybody. So following on from my colleague Anura, who presented performance, I'll be looking at considerations for implementation, particularly in the program-wise, but also considering laboratory perspectives, and then applying these to our setting in South Africa. And I have no conflicts or disclosures. So really, following on from Anura, the World Health Organization had made initial recommendations early in 2021, this year, in terms of the use of nucleic acid amplification tests to detect TB and drug-resistant TB, and classified 3 classes of technologies and their associated products into high, moderate, and low complexity assays, of which only one product, the product in discussion, the Xpert MTB XDR from Cepheid, in the low complexity category. And based on available evidence early in January, they supported the use of these assays, including the low complexity assay for detection of isoniazid and the second line anti-TB reagents. So very recently, the updated guidelines and operational handbook from the WHO includes further scope and recommendations on the low complexity assay. And with respect, with low complexity being defined as where no special biosafety infrastructure is required and only basic laboratory skills are required in addition to the equipment to perform the test. So there were 3 recommendations. The first one, in those bacteriologically confirmed pulmonary TB, the assay could be used off sputum specimens for the initial detection of resistance to isoniazid and fluoroquinolones, as opposed to phenotypic drug susceptibility testing. The second recommendation was, in addition, where pulmonary TB has been bacteriologically confirmed and rifampicin resistance has been identified, the assay could be used for initial detection of resistance to ethionamide rather than sequencing the INH promoter region. And the third recommendation was also extended for the use of the assay to detect initial resistance to amikacin as compared rather than using phenotypic drug susceptibility testing. So these recommendations were based on evidence of the diagnostic accuracy in sputum of adults with confirmed pulmonary TB, but could be extrapolated to both adolescents, children, and also in the extrapulmonary TB setting, and also replicable to people living with HIV. So based on the available evidence at the time, pooled sensitivity and specificity for the various drugs was also reported by the WHO for isoniazid and fluoroquinolones and amikacin, where the comparator was culture-based DST. Isoniazid and fluoroquinolones pooled sensitivity was greater than 90%, amikacin 86%, and for ethionamide, where the comparator was sequencing of the INH promoter, 98%, with a fairly high sensitivity, specificity across all agents. So only amikacin was included because kanamycin and capreomycin are currently not recommended for as second-line injectables in the use of treatment regimens for drug-resistant TB. So in considering, implementation, it's important to know some key characteristics of the assay, some of which have been mentioned by Anura. But like Xpert MTB RIF and Xpert MTB RIF Ultra, the cartridges are self-contained to minimize cross-contamination. It allows a simultaneous detection of both of MTB complex and then the resistance associated with the isoniazid, ethionamide, the fluoroquinolones, and the second-line injectable drugs, with the gene targets represented in the table below. There are built-in controls, both a sample processing control to monitor PCR inhibition and probe check controls. And just like Xpert Ultra or Xpert MTB RIF, the technology allows for random access, with the Xpert MTB XDR result available in just under 90 minutes, as compared to the Xpert Ultra just available in less than 80 minutes. And in terms of throughput, 5 tests per module within an 8-hour shift. So limit of detection is important, with that reported for the Xpert MTB XDR as 136 CFUs per mole for raw sputum, slightly lower in concentrated sputum specimen. And then I've included the limits of detection for the previous version of the Xpert cartridge and that for Xpert Ultra. So really the assay is meant to be used as a reflex test once Xpert MTB RIF or the newer version, the Ultra, has identified the presence of MTB and rifampicin resistance has been detected. And this is either off residual specimen or concentrated sputum specimens. And in terms of storage, storage of cartridges at room temperatures and storage in terms of actual specimens for processing, unprocessed can be stored or tested up to 7 days if stored at room temperature, and if refrigerated, up to 7 days for sputum sediments. So linking to point 5 above, and that this was designed to be a reflex, this needs to happen within a very narrow processing window. And so once the specimens have been processed with the addition of sample reagent buffer and testing for Xpert MTB RIF or Xpert Ultra has commenced, the processing window then commences. So if the residual specimen, SR-treated specimens, are refrigerated, that processing window is approximately 4 hours to reflex to the Xpert XDR. But if the residual SR specimens are not refrigerated, the processing window narrows to 2.5 hours. So this has implications for laboratory workflow. Equally, to be able to achieve or conduct the reflex successfully, the initial starting volume of specimen is critical. So additional operational requirements is that both Xpert MTB RIF and Ultra use 6-color functionality. The Xpert MTB XDR uses 10-color functionality, and this was designed to increase the degree of multiplexing. And so technology may be procured either as new modules with 10-color functionality, either as complete new instruments or systems, or as satellites where an existing 10-color module is incorporated into existing infrastructure. And in terms of compatibility, the smaller modules from the GX1 up to the GX16 are compatible, currently not offered on the Infinity platforms. And there are also a series of software requirements to be able to run the assay. So to summarize again, is that the reflex really following detection of TB and rifampicin resistance is direct reflexing off the residual SR-treated specimen to the Xpert MTB XDR. But there's another role, and that is because the cartridge can identify isoniazid in settings where there may be isoniazid resistance may be high. This could be another feature, reflexing off rifampicin susceptible result to acquire information about isoniazids. So some considerations for implementation in terms of programmatic. First of all, one would need to consider the epidemiology, so the rates of both isoniazid, rifampicin, and other drug resistant, what the local diagnostic algorithms are for detection of drug resistance and the detection of TB, but also the number of baseline specimens that are collected within that algorithm. And we'll expand on this as I progress on the slides. What the existing infrastructure is, whether the testing is centralized, decentralized, whether 10-color modules are available already, what the operating software versions, and also whether the program is still testing Xpert MTB RIF or has progressed and is testing the more sensitive Ultra. What the drug-resistant treatment regimens have been adopted, whether the shorter oral have been adopted, and also costs. So it's not only the costs of tests, but it's also the cost of the instrumentation. And it doesn't necessarily mean that every single result performed by or reflexed to Xpert XDR is going to be successful. So additional testing, if the result is indeterminate or invalid, also needs to be factored in. And so with this assay, we may be detecting a resistance and initiating patients on treatment, but a link to the cost is also the total resources as we steer or diagnose more resistance or more individuals that enter into the treatment program. So really, local costing exercises would be important and also linked to what the existing algorithms and their current standards of care are. And then in terms of laboratory perspectives, there are both pre-analytic, analytic, and post-analytic components to consider. That implementing initial specimen volume is critical, and whether the type of specimen, only pulmonary or pulmonary and extrapulmonary, the testing volumes that are being envisaged to be tested, and link that to the supply chain management. And then in terms of analytical, what the workflow processes are going to be, considering the requirement and the reflex processing window, the refrigeration capacity to maximize the processing window for the reflex, and additional technical aspects. And then post-analytically, with the introduction of a new test, what do the results mean? How are these actioned in terms of clinical management, etc.? So applying now these principles and using South Africa as an example, certainly in terms of our epidemiology, we not only have a high burden of TB, but also have a high burden of drug-resistant TB and high rates of TB and HIV co-infection. And although our incidence has declined significantly, our treatment success rates are not ideal for drug-resistant TB. In terms of diagnostic algorithms, so we have a complex algorithm to identify rifampicin resistant. And as I mentioned earlier, this tends to, the number of specimens initially collected is very important. So in our algorithm, there are differences by province, with the majority of provinces collecting a single baseline specimen for investigation in presumptive TB cases, and a single province collecting 2 upfront specimens. These are then channeled for testing in the decentralized Xpert Ultra network, and where MTB is detected and rifampicin resistance identified, should additional testing obviously be required, most provinces then require collection of an additional specimen, whereas one province, since 2 were collected, 1 is already available as it's retained by the lab. So further testing then happens at a centralized level in the TB culture laboratories, where specimens are digested, decontaminated, concentrated, and split for both smear, culture, and the Hain-Brucker first line and second line LPAs, together with drug susceptibility testing for particular drugs. So considering the algorithm and where Xpert XDR would be implemented, so certainly as a reflex, provided adequate specimen volume remains, the reflex would be successful, but then there would be no specimen for phenotypic DST. And so that one would still have to collect an additional specimen. If the volume of residual SR-treated specimen is insufficient to collect or to reflex to Xpert XDR, one would still require an additional specimen for the XDR, and then potentially there would also be a need for a third specimen for DST. So those factors have to be considered. And so ideally, where rifampicin resistance is detected and you cannot reflex due to insufficient volume, the additional specimen, it rather makes sense to be referred to the centralized testing lab so that the Xpert XDR could be run in parallel with the TB culture being set up for DST. So these are some of the intricacies associated with whatever algorithm is available. And then in this setting, where the second specimen is available, reflex testing could actually progress as, as required and also be referred to the centralized lab. So the other consideration is where either starting volume is not adequate or only a single baseline specimen is collected, we have to consider the losses in TB care cascade by requesting additional specimens, and that's another consideration. And although I'm discussing only the procedure for rifampicin resistance and reflexing to Xpert XDR, there are other considerations in the algorithm, particularly because our program uses Xpert Ultra. So around 2% of our results report MTB trace detected. And knowing earlier the limits of detection, we would know that around 2% of our results, all identifying trace, could not be reflexed to the Xpert XDR as MTB would not be detected. So we also have to cater for this branch of the testing algorithm. And again, then wherever it's a retained or additional specimen, these would have to be referred to the centralized TB culture laboratories, await a positive culture. If positive, then potentially to test ultra. If rifampicin is resistance is identified, then reflex to XDR, and culture's already been set up in parallel for phenotypic DST. So what is the available infrastructure as a consideration? So although our program is highly decentralized across 165 labs, we would have to consider the rifampicin resistant rate. Our current detection rate is around 9%, and of that 5% reports rifampicin resistance. And so it's conducive that the implementation of the Xpert MTB XDR would follow a decentralized plan, and where either insufficient volume is available to reflex, any additional specimen would rather be referred to the centralized TB culture laboratories, so that further testing could be done with culture in parallel for phenotypic DST. And pre-COVID, all our modules were on 6-color functionality. And there was a further investment at the start of COVID to incorporate COVID testing into the program. So around just less than 10% of our modules already have 10-color functionality. So that's a plus in our setting, but maybe a constraint for additional investment in other settings. And our rifampicin resistant also varies by district. So this also needs to be factored in how various labs are capacitated to deal with additional reflexing to the Xpert XDR. So in terms of now laboratory considerations in our setting, I've emphasized initial specimen starting volume. And so our program has been running for just over a decade, and the majority of our specimens are far less than 2 mils starting volume. So that is going to be another impact factor in how this is implemented, and would require additional interventions such as training, collection, to ensure that the process is seamless and that the adequate volume as the primary initiating event to allow the sequence of testing to proceed. In our program, up to 2% of all our specimens are extrapulmonary in origin. And so to meet in-country regulations, we would have to conduct verifications around these specimen types. So coming to analytical considerations, so trying to meet the workflow process and the refrigeration needs once on the residual SR treated specimen. So this may be feasible in very small labs that test low numbers and have low rates of rifampicin resistance, but may actually become a problem in higher throughput laboratories with high rifampicin resistant rates. And so trying to achieve that 4-hour processing window, considering that all of these specimens and residuals need to be refrigerated, need to be adequately labeled so that they can be accurately retrieved again, depending on the result, it may not necessarily be possible in high throughput labs. So that's another consideration. And I guess further research and development around how can that processing window, can it be extended, and what is the impact? So there are also technical aspects that if no resistance is identified, it certainly doesn't confirm susceptibility, and also considerations around specimens where more than one strain may be present, and the proportion of those may influence the result. So also in discussion is we have an existing drug-resistant TB reflex in the centralized labs. So could Xpert XDR actually be a complete replacement strategy for the Hain-Brucker first line and second line line probe assays? It would mean that there would essentially be no existing change to the drug-resistant TB reflex. The targets are the same for the drugs, except that there's slightly higher INH sensitivity with 2 additional targets for INH in the Xpert XDR cartridge. And culture would be performed in parallel for phenotypic DST. And we know that the first line and second line probe assays performance is highly dependent on smear status. And so as opposed to waiting for culture to repeat line probe assays, results may actually be available much sooner, and it will also significantly decrease the expertise required in terms of workload and expertise in performing the line probe assays. So that's another consideration that's being looked at. And then post-analytically, as I mentioned, introducing a new test, reporting of the test and how this gets translated into the clinical context for initiating treatment, linked with guidelines. There may be an impact on clinical management that these results will be available much sooner as opposed to our current standard of care. But in instances where initial specimen volume was not adequate, or you're unable to reflex and you require additional specimen, you're not always guaranteed that TB will be detected in the second or additional specimen. And so you're not always going to have Xpert MTB XDR results much sooner if the reflex, if not following directly to the reflex. So, and in addition, the latest updated WHO guidelines for pre and XDR TB, the XDR cartridge could at best identify pre-XDR, and so these definitions also need to be incorporated within the overall TB program and the clinical algorithms going forward. So in conclusion, the provision of molecular DST by Xpert MTB XDR has numerous advantages, from its low complexity, the ability to integrate into decentralized testing, and nearer to point of care, faster time to results, early detection of fluoroquinolone, either for the shortened drug-resistant treatment regimens or in certain settings where the shortened drug-sensitive TB treatment regimens incorporating fluoroquinolones are adopted. It would be useful. Certainly impact on clinical care, earlier availability of results, initiating more patients, but there are also key considerations in terms of the lab, considering the local epidemiology, the workflow in terms of achieving the requirements for reflexing, whether additional specimen and testing is required, etc. And I've reached the end. And I'd just like to acknowledge many of the groups who've been part of the initial discussions around potential implementation of the Xpert XDR cartridge within the South African program. Thank you.
Thank you, Pedro. There are a number of questions in the chat box, so we'll move to that. If you have any additional questions, just post them into the chat box. So the first question comes from Sindani Sebit, and is asking, I think this study is overtaken by the recent definition of XDR TB, which is no longer based on inclusion of injectable drug resistance. With the introduction of all oral drugs, injectable drugs are no longer useful in the definition of XDR TB. So how would you respond to that? So Anura or David, you can take that. Anura or Pedro, sorry.
Okay, so I think like Pedro mentioned in his presentation, the definitions of pre-XDR and XDR were just recently changed in 2021. And this assay, actually, we did the performance evaluation, and it was actually, well, not launched, it was evaluated in 2019, 2020. So obviously with the changing definitions, it's now no longer for diagnosis of XDR, but rather pre-XDR TB.
Okay.
And I can add, yeah, so I think also mentioning, you know, the XDR cartridge development started several years ago, and it was based on previous definitions. And so it is the Xpert XDR, but based on the updated guidelines, as I mentioned, it can only identify pre-XDR. And so that needs to be factored in whatever the implementation or the local specific algorithms as they are developed.
Okay. The second question is for Anura, and it's asked by Ndlovu Sibusiso. He wants to know why the smear negative samples were more prone to XDR invalid rates of up to 6%.
So I don't know if we could make a definite conclusion as to why this was, because if you looked at my participant cohort slide, only 24% of samples tested were smear negative. So I think it was just because of the proportion, you know, there were a high number of, well, they were invalids, but out of a smaller total. So the proportion is what affected the invalid rate here.
Okay. Another question is from Bodena, and it's also asked by Banabe if other sample types can be used. So can Xpert MTB RIF detect lung tissue and rectal swabs with good sensitivity and specificity? And what about other samples?
So I can answer that. So the question is Xpert MTB RIF, not XDR. So there are recommendations from WHO for extrapulmonary specimen types. And in our experience, we have fairly good yield with tissues. I'm saying tissues in general. I don't want to comment on lung tissue, but we don't process rectal swabs. And a rectal swab is not a recommended specimen type currently on the, as per WHO guidelines. Although I think for Xpert MTB RIF, stool is included, but not on the Xpert MTB RIF Ultra as yet.
Okay, thank you. The next question is from Tran, and he wants to know the target for MTBC detection in XDR cartridges. Is this a reason of invalid MTBC detection in XDR cartridges? Why is MTB positive in Xpert MTB RIF? Yeah, so there are a number of questions. I don't know if you get the flow, but he wants to know what should the lab interpret in case of discordance? Yeah, so I think we can address the discordance and how to deal with it in the lab, basically.
Okay, so, I guess it depends on whether you've tested as a reflex or you've tested off an additional specimen. So there might be sampling dynamics which differ if you're testing off additional specimens, and that's one of the caveats that I mentioned. Your Xpert MTB RIF may identify TB in the one specimen, but if you're then collecting another to progress to Xpert XDR, hopefully you should be detecting TB, but if you don't detect TB, it doesn't mean that it's a true discordant. There may be pre-analytical factors involved, such as which have influenced the collection of the second specimen. So if you're testing as a reflex and you identify, since the limits of detection are similar for Xpert MTB RIF and the XDR, if you're testing as a reflex, then you should be able to identify MTB complex by both assays. This is not necessarily the case with Xpert Ultra, because the targets that identify, for example, a trace result, it relies on the insertion sequences, and the limits of detection are very different. So that is why reflexing off an MTB trace detected result is not recommended by for the Xpert XDR results. So I think if there's a discordant, I think one would need to look at the pre-analytical processes. Is it the same specimen? Is it reflexed from a positive specimen, etc.? I hope I've answered the question.
Okay, thank you. Another question from Dr. Pascal is, at what level of the network, the laboratory network, is the test anticipated to produce the best results?
Well, the assay is designed to be performed as a reflex. So it depends on where you have. If you have a decentralized network, then the test should be offered wherever your Xpert MTB RIF or Ultra is being offered. That is where the Xpert XDR should be offered. And it's designed to be performed as a reflex so that results are available within the same day, within a short period of time. But this obviously depends on the setting, and there might be other factors which ultimately influence the decision. But Xpert XDR should really overlay what the existing infrastructure is for Xpert MTB RIF or Ultra.
Okay. Then we have another question in the chat from Peter Gumbo, and is asking about advanced HIV disease and how we can test this group of people since the production of sputum is low. What would you say about that?
So I think, you know, with the advent of the Xpert Ultra cartridge, it's been shown that in people living with HIV, that sensitivity is significantly improved. And that is one of the major advantages of the Xpert Ultra cartridge. So if using the Xpert Ultra cartridge to identify rifampicin resistance, and it is detected and MTB is detected, there's no reason why Xpert XDR should not also provide a valid result once reflexed off that specimen.
Okay. Then there's a long question from Kathleen England. So I'll ask her to unmute and ask the question.
Hi, Pedro. Yes, so I'm wondering if you can try to explain the scenarios where you would do I mean, you've gone through reflexing, but I think my question is the recommendation for reflexing related to the scenario within different countries, because you can do it off of MTB positive if RIF resistance is not detected, if you know you have high levels of fluoroquinoline resistance floating around. When basically do you decide to do reflexing, basically, and what are the conditions for that when you're making your algorithm?
So you'd have to consider all the local factors. So what's the current standard of care? So, you know, currently we have high rifampicin resistant rates, but we also have high isoniazid rifampicin resistant rates. So the discussion really is about your epidemiology and where this assay can be better suited. So we do phenotypic DST on all specimens where rifampicin resistance is identified, because we want to gather information and we want to know details about the fluoroquinolone resistance. So I think it has to be locality specific in terms of how the reflex is applied. So we are considering multiple options, either highly decentralized or initially as purely a replacement strategy for the line probe assays, which sometimes are problematic in terms of their performance. And then that then needs to feed in from information such as prevalence surveys, etc., of what they are identifying.
I guess that's not clear. That wasn't clear. So I think in many cases, you use a patient's treatment history to decide, okay, once you get the RIF resistance, should we go on? But sometimes, especially in South Africa, we see a huge rate of transmission and people who don't even have a treatment history. So when is it standard to do a reflex, or do you have to, how would you do that case by case? Those are the kind of questions.
So purely, remember, this is purely from a laboratory perspective. Sometimes we don't have all the clinical details. So there's an existing algorithm. Anybody that's being investigated for TB would have a GeneXpert Ultra upfront. And if rifampicin resistance is identified, it then triggers the drug-resistant TB reflex. So that is standard, irrespective of you know, whether they've been previously treated or whatever. As a lab, if that specimen comes in, those reflexes would apply. And hence the same thing. If rifampicin resistance is detected on that specimen, we would likely then reflex to Xpert XDR. I'm not sure if I'm answering your question.
I think you are for South Africa scenario, but for other countries, there may be some differences. That's my point.
Yeah. Yeah, I think I was trying to elaborate on that, that would be region or country specific and is not generally generalizable to all settings.
Okay. The other question is from Pascal as well, asking if you considered XDR prevalence in deciding where to implement the assay.
So we haven't implemented the assay yet. These are all the discussions at the moment, and all those considerations have to be taken on board before a final decision is made.
Okay. The other question is on the presence of resistance gene. So the questioner says, did the presence of resistance genes necessarily equate to treatment failure, as resistance is also dependent on the mode and level of expression of the genes?
I'm sorry, who asked that question? I need to read it, otherwise.
Okay, I think because there are so many questions, we'll still reach you to respond to them so that we can share with the participants. So yeah, so let me ask one final question from Nora Odidi. And she's saying, I think the cost implication will be a big setback in implementing the XDR cartridge in most facilities, as we must upgrade to the 10 color modules. What are your thoughts about that?
So I I tend to agree. And the costs need to be looked at, the existing infrastructure, and you know, if in settings where resistance is low, is it feasible? You know, all those considerations need to be looked at. In areas where resistance is much higher, so as I said in our example, we already have 10% of modules that have 10 color functionality. So that for us is not an issue, but maybe a significant barrier in other settings is the cost of acquiring the additional instruments or modules that have 10 color functionality.
Thank you. Maybe a final question to Anura on whether long-term storage of the cartridges has an effect, and also whether storage of samples has any effect in the results, like freezing samples at -80.
Okay, sure. So with regard to storage of samples, I think, I don't know it offhand, but I know Pedro did present a little bit of what storage temperatures are acceptable and for the periods of time that they can be stored before testing. And then, sorry, I didn't get your question on the storage of Xpert cartridges.
Yes, somebody was asking about the long-term storage at room temperature, if it has an effect on the performance.
So when we performed the evaluation, the XDR cartridges had to be stored at fridge temperature and then thawed to room temperature just before use. I don't know if that's changed since then. Maybe somebody from Cepheid can comment on that.
So maybe Gwen?
Devasina, do you want to take that question?
Can the person raise the hand? Then we can unmute.
Sorry, I wasn't able to unmute. So no, that has not yet changed. The requirements are still the same to bring the cartridge to the room temperature.
Okay, thank you so much. So probably I'll take a final comment from Anura, followed by Pedro.
I just want to say thank you for the opportunity to present, and thank you to everybody for the really good questions. I think the discussion was really good and helpful, and also stimulated further questions and thoughts. So thank you.
Thank you. Pedro?
Yeah, thanks everybody for inputs and for the opportunity to present. And just to end that there's really a lot of considerations for implementation of this of this new diagnostic.
Okay, thank you. So we thank all the participants. Sorry, we are not able to answer all the questions, but we'll be reaching out to the presenters to get the questions answered, and will be shared with you through the mailing list. We'll also be sharing the slides and also the recording as been indicated. Also remember that the ASLM 2021 is open and abstracts are welcome up to 30th July or 31st July. So please send in your abstracts. Otherwise, good evening, good morning, and good day. Thank you for attending.
Thank you.
Thank you, everybody.